All right, I think we'll start. Good morning and welcome to the Hamilton Health Sciences Grand Rounds and this cold wintry morning. As usual, for quick housekeeping, we'll start with our presentation from our speakers, and then we'll go into a Q&A period. For the Q&A, you have the option of putting on your questions in the Q&A section, or if you want to bring in your question in person, please raise your hand. I'll monitor that and I'll bring you in at the end to speak. There's also the chat function, but please avoid putting questions in the chat function. If you want to put any comments, we'll try to monitor that as well. I'll start with the land acknowledgement. We are privileged to provide care on lands that indigenous peoples have called home for thousands of years. I want to acknowledge that I'm situated upon the traditional territories of the Haudenosaunee and Mississaugas. This land is covered by the dish with one spoon, one bomb agreement between the Haudenosaunee and Anishinaabe, and all of us on this land to share and care for the resources around the Great Lakes. Understanding that this is a virtual event, I'd like to ask you to please take a moment to reflect and give thanks to those who have come before you on the lands on which you currently reside. All right, today we have three wonderful speakers. They're our PGY3s who have achieved at Hamilton Health Sciences Hospitals. Abdullah Alalaiyan, Amena, Alhammadi, and Alexandra Kobza are all in PGY3s at McMaster Internal Medicine Residency Program. Abdullah will be pursuing a fellowship in critical care at University of Toronto. Amena will be joining the infectious disease program here at McMaster, and Alex will be heading to Calgary to start training in rheumatology, which is closer to home. The faculty supervisor for this presentation is Dr. Teboni, who is a general internal medicine general internist at St. Joe's, and she is the medical director of the bariatric training program. So without further ado, I will just pass on this to Abdullah, and he can start.
All right, good morning, everyone. And thank you, Dr. Azam, for the kind introduction. Today, we aim to present an overview of the principles important to the care of patients with excess body fat. And our presentation will be based upon the most recent published guidelines. You may ask, why is it important that we talk about this? It is important because obesity and its related diseases have both significant impact on patients' health and financial impact on the healthcare system. These patients are more at risk of developing serious chronic illnesses such as diabetes, heart diseases, cancers, and liver diseases. As a matter of fact, we estimate that the care of patients on the spectrum of obesity is costing the healthcare about $4 billion every year. Obesity has been linked on multiple organ problems and diseases. And in the era of the pandemic, it has been proven that patients with obesity are more at risk of finding themselves on the severe course of COVID-19, giving those collateral health issues that we can see in this slide. And the CDC also confirms the risk of severe COVID-19 illness that increases sharply with elevated BMI. Going through definitions, in the past decade or so, obesity has been defined as a complex chronic disease in which an abnormal or excess body fat that impairs health, increases the risk of long-term medical complication, and reduces lifespan. The WHO consider as obesity any individual with BMI above 30, and then they divided them into three subgroups ranging from BMI over 30 all the way to BMI above 40, which is classified as class 3 in their scale. According to Statistic Canada in 2018, about 10 million adult Canadians reported being overweight, and roughly 7 million were considered obese, and 2 million were in the severe obese category. And in Canada, severe obesity is defined as BMI above 35. And all that to say is that 63% of Canadians are dealing with excess body fat. This is a map distribution, and on this map, the colors are used to indicate which provinces have the prevalence of obesity significantly different from the national average. It is important to note that the national average of obesity in Canada is roughly around 20%. In category 1 is colored green and represent the provinces that have obesity prevalence significantly lower than the national average. In category 2 is colored yellow and represent provinces with prevalence of obesity not significantly different from a national average. In category 3 is colored orange and represent the provinces that have the prevalence of obesity significantly higher than the rest of the country. Now we begin the journey of evaluating a patient with obesity. These are 5 steps in patient journey to guide the healthcare provider in the care of patient living with obesity. Each step is outlined with highlights of the relevant recommendation and discussions with supporting evidence. We're going to walk you through each step of these. First step, and first things first, as doctors, we acknowledge that obesity is more than just condition. We have to acknowledge that obesity is just more than just a condition, and now it's been recognized as a chronic disease that requires individualized treatment and long-term care plan. And because of that, we need to establish rapport with patients and start asking them for permission to provide them support. Also, we need to acknowledge the stigma that this population go through. And one thing to do that is through assessing our own bias in the healthcare. And one helpful way of doing this is to take the implicit association test, which we're going to talk about more in depth. This is a survey that conducted by the Canadian Obesity Network reveals that weight bias is widespread in our society. And sadly, though they found out that 63% of kids with obesity are at greater risk of being bullied at school, and 53% of adults reported being stigmatized at work. And 70% of people with obesity in this study reported having been a victim of a weight bias of a healthcare professional. This is a sample of the implicit association test. Excuse me. It is a self-assessment tool that has been put together by Harvard University, and it contains a list of questions that we can ask ourselves to determine if a healthcare professional have a preconceived ideas about people presenting with excess body fat. Just to give you an example, one of these questions reads as follows: what assumptions do I make based only on weight regarding a person's character, intelligence, professional success, health status, or lifestyle behaviors? I'll give you a few seconds just to read the rest. Step 2, which is patient's assessment. And now once we have assessed ourselves on where we stand in regard to obesity and taken the permission from patients and earned their trust, we're ready to start assessing patients through a holistic approach with a focus on health behaviors. Then we look for possible root causes such as genetic factors and identify associated chronic diseases and check for obesogenic medication and consider cultural practices and beliefs, as well as psychological factors. Of course, we need to complete a comprehensive physical exam and take a history to rule out common related diseases. And it is imperative to obtain direct measurements of height, weight, waist circumference, and as well as calculating the BMI of the patients. It is also recommended to use the Edmonton obesity staging system to better characterize the severity of the obesity-related morbidities. The Edmonton Obesity Staging System is a 5-staging system that considers metabolic, physical, psychological parameters into account, along with the BMI, in order to determine the optimal obesity treatment. As we see in this table, for instance, a patient with no obesity-related diseases, no physical restrictions, or psychological barriers that affect their well-being, they would fall under stage 0. Where a patient with CHF, for instance, type 2 diabetes, and severe osteoarthritis, restricting their functional status of daily living, in addition to severe depression and anxiety, would fall under stage 4. So instead of relying strictly on BMI to urge patients to lose weight, using the Edmonton Obesity Staging System can help identify those patients who are at higher risk of mortality and a greater need of weight management and reduction. Step 3, which is discussion with patients' treatment options. So at this point, we should have a good overview of our patient's condition, and we can start discussing the options, and such as providing them support for behavioral changes, discussing psychological aspects if needed, providing them with medication, potential surgeries, which we're going to talk about with my colleagues in a few minutes. Fourth step, and when our patient has a good understanding of the options available and is ready to commit to making some changes, it is important to agree on realistic expectations and sustainable goals. And that is important to increase the chances of success and to improve the overall health. Step 5, acknowledge and advocate. There are substantial barriers affecting access to obesity care in Canada, including a profound lack of interdisciplinary obesity management programs. We have to keep in mind the long wait times for referrals and surgeries and the high cost of treatments. The lack of access to obesity treatments is contributing to the rising levels of severe obesity in Canada in the past decade. There is a need for constant advocacy in that matter, and starting with more education and lifelong learning within the medical community to be able to deliver effective and evidence-based obesity care. Now we'll start with the management part.
Thank you, Abdullah. Once we're done with the assessment part, now I'll take you through the initial management in the adult living with obesity. Adult living with obesity should, Abdullah, next please. Okay, adult living with obesity should receive an individualized care plans that address their root causes of obesity and that provide support for behavioral changes as well as adjunct therapies. Medical nutrition therapy is a foundation for chronic disease management, including the obesity management. However, it shouldn't be used in isolation in obesity management, as sustaining weight loss may be difficult long-term because of the compensatory mechanisms in the brain that will eventually lead to weight gain. And instead, medical nutrition therapy in combination with other interventions, psychological, pharmacological, and surgical, should be tailored to meet an individual health-related and weight-related outcomes. Next, please. Now let's chat about the nutrition. A nutrition recommendation for weight loss should be personalized to meet individual values, preferences, and treatment goals to support a dietary approach that is safe, effective, and nutritionally adequate, as well as culturally acceptable and affordable for long-term adherence. While possibly counterintuitive, randomized clinical trials do not support improved weight loss when based upon patient food preference. In fact, meta-analysis suggests that patient choice in weight loss strategies have no significant effect on duration or attrition, with the greater weight loss often occurring in the control groups. However, effectiveness of any therapeutic intervention is likely enhanced when patients are engaged and agree to treatment plans. Adult living with obesity should receive individualized medical nutrition therapy provided by a registered nurse whenever available to improve weight outcomes, waist circumference, glycemic control, and establish lipid and blood pressure targets. Next, please. It is encouraged to use foods that result in a negative balance to achieve and maintain a healthy weight. It is not only about what you eat, but how you eat. Here are some principles to be considered. First of all, eating behavior and meal patterns. Some examples of that would be avoid late night eating, take time to eat, be aware of when you are hungry and when you are full. Please take into consideration the cultural background, traditions, and food availability. It is a reality that unhealthy food is widely available and probably cheaper than healthy food. Always encourage nutritional knowledge and cooking skills. Advise your patient to cook more often, eat out less. Advise them to enjoy their meals with friends or families. And always be mindful of the medical condition potentially affected by the nutrition plan. Next, please. Nutritional approaches for weight loss typically focus on caloric manipulation of 3 macronutrients, which are carbohydrate, fat, and protein. This is a suggested algorithm for energy consumption intended to cause negative calorie balance or loss of fat mass. As you can see, it is divided into low-calorie diet versus very low-calorie diet. The low-calorie diet is usually 1,200 to 1,800 kilocalorie per day, and it is further subdivided into fat or carbohydrate restricted. Restricting dietary fat usually leads to a greater reduction in total and LDL cholesterol, whereas restricting dietary carbohydrates lead to a greater reduction in serum triglycerides and an increase in HDL cholesterol, and it can lead to a greater reduction in serum glucose and HbA1c. As you can see that the low-fat diet is usually defined as 10 to 30% of total calories from fat, while the carbohydrate diet is generally defined as 50 to 150 grams per day, in contrast to a very low carbohydrate diet that is less than 50 grams per day. On the other side, the very low caloric diet, which is less than 800 kilocalorie per day, it usually requires a close medical supervision for safety reasons. And as you can see, it basically is consistent of shakes, bars, and soup, which largely replace the meals. And it's usually recommended for shorter durations. Next, please. Here are some principles of healthful nutrition. Please encourage your patient to limit unhealthful ultra-processed food of minimal nutritional value. Advise your patient to limit energy-dense food and beverages high in calories, and encourage avoiding using any trans fats or excessive sodium. Next, please. Encourage your patient instead to increase consumption of healthful food. Increase complex carbohydrate over simple sugars, which turns into low glycemic index over high glycemic index. Encourage high fiber foods over low fiber foods, and encourage many dietary products, but be mindful of their caloric content. Always advise your patient and encourage them to read label to increase their awareness and allow them to be able to compare products. Next, please. This slide shows you some examples of many dietary plans, but must be calorically restricted to effectively treat obesity. Weight loss and metabolic effects vary between them. At this point, further details and guidance on dietary plans are usually offered by the dietitian. Next, please. Okay, let's move to the physical activity part. Regular physical activity with or without weight loss can improve many cardiometabolic risk factors in adults who are overweight or obese, including diabetes, hypertension, and dyslipidemia. Next, please. Aerobic activity for 30 to 60 minutes on most days of the week can lead to weight and fat loss, improvement in cardiometabolic parameters, and weight maintenance after weight loss. Next, please. On the other side, resistance training may promote weight maintenance or modest increase in muscle mass or fat-free mass and mobility. In fact, increasing exercise intensity, including high-intensity interval training, can achieve greater increase in cardiorespiratory fitness. And as we all know, that regular physical activity can improve health-related quality of life, mood disorders, and body image. Next, please. This slide basically shows you the current recommendation for the physical activity to achieve and maintain weight loss. It is encouraged to combine aerobic activity as well as resistance training To be able to achieve activity goals, it is advised to do a minimum of 5,000 to over 10,000 steps per day, and or 150 to 300 minutes or more of moderate intensity aerobic activity per week, or more vigorous intensity aerobic activities per week. That is in combination with resistance training at least twice per week. Next, please. Now we'll move to psychological and behavioral interventions. All health interventions, such as healthy eating, physical activity strategies, medication adherence, and surgery preparation and adjustment approach, rest on behavior change. Psychological and behavioral interventions are the how-to of change. They empower the clinician to guide their patient toward recommended behaviors that can be sustained over time. Multi-component psychological intervention should be incorporated into care plan for patient for weight loss and improved health status and quality of life in a manner that promotes adherence, confidence, and intrinsic motivation. Next, please. Here are some principles to guide your management. As a provider, eliminate bias and stigma. Provide nutritional education. Encourage your patient to develop strong support system. Address their stress management, and don't forget to optimize their sleep. You can use other psychological support methods such as cognitive therapy. Encourage combining behavior modifications such as goal setting, self-monitoring, and problem solving. Encourage development of confidence in overcoming barriers and intrinsic motivation, such as setting a goal that is personal and meaningful reason for them to change. And lastly, setting a goal that is realistic and achievable to avoid any future disappointment. Next, please. Overall, the weight loss achieved with usual health behavioral changes is usually 3 to 5% of body weight. It can reach up to 8% with intensive lifestyle changes, which can result in a meaningful improvement in obesity-related outcomes. The amount of weight loss varies substantially among individuals, depending on biological and psychological factors, and not simply on individual effort. If more than 3 to 5% body weight reduction is required, at this point, more intensive pharmacological and psychological therapeutic options should be considered. And my colleague, Alex, will take you through this.
So now let's talk about the pharmacotherapy that's available. So we've been searching for a magic weight loss pill for about the last 100 years. So let's talk about what is currently available and what is coming down the pipeline. So pharmacotherapy is indicated for patients with obesity in Canada who have a BMI over 30 or over 27 with related comorbidities. It can also be prescribed to maintain weight loss that has been achieved by health behavioral changes. Next slide. The first medication was approved in 1999. This is orlistat, and it is a reversible inhibitor of gastric and pancreatic lipases, inhibiting the absorption of dietary fat by about 30%. Patients can expect to see a mean weight loss of about 6 to 8%. And as you can imagine, common side effects include steatorrhea, fecal incontinence, and decreased absorption of the fat-soluble vitamins. Next slide. The next medication is naltrexone bupropion, also known as Contrave, and this was approved by Health Canada in 2018. Naltrexone is a pure opioid antagonist, and bupropion is a relatively weak inhibitor of neuronal reuptake of dopamine and norepinephrine. The mechanism in weight loss is unclear. Mean weight loss is about 8%, and this medication cannot be used in patients who use opioids chronically, those with seizure disorders, and patients who are using MAO inhibitors. Next slide. The third medication was approved in 2015. This is liraglutide, and the weight loss formulation is Saxenda. This is a GLP-1 receptor agonist that many of you may recognize from Obesity Management. The dose in Obesity Management is 1.8 milligrams daily, and the maximum dose in that's in diabetes management. And in obesity management, the maximum dose is 3 milligrams daily. So GLP-1 is hormone secreted by the L cells of the small intestine. Food intake stimulates its release, which increases insulin secretion, slows gastric emptying, increases satiety, reduces cravings and hunger. Patients see a mean weight loss of about 8%, and common side effects include nausea, vomiting, and constipation. So all three of these medications give us a weight loss of about 5 to 10%, which is similar to what can be achieved with intensive lifestyle management. So weight loss to this degree certainly produces meaningful changes in health, but greater weight losses, of course, are going to give us better results. Next slide. So currently, this is how we're using these therapies in Canada. So at the 1 month mark after starting a patient on a medication, we're going to assess for side effects and reinforce those good lifestyle changes. Then at the 3 month mark, we're going to assess how effective our therapy is. If there's been less than 5% of total body weight lost, that would be a non-responder. And so we should stop that medication and start a new one. 5 to 10% weight loss would be a partial response, where we should continue the medication, but try to increase the dose. And more than 10% weight loss would be a highly effective medication for that patient, and we should continue the medication. Patients often see a plateau in their weight at a new set point, and they need to continue the medication to stay at that set point. Next slide. Of course, another option is bariatric surgery. So the criteria for this in Canada is to have a BMI over 40 or between 35 and 40 with at least one medical condition. Patients need to be smoke-free for 6 months and be under the age of 70. Patients typically initially see a weight loss of about 25 to 30%, and there is typically a bit of weight gain following that, where at 3 years, the total weight loss will be about 20 to 25% of their original weight. Next slide. The two surgeries that are covered by OHIP are the gastric sleeve you see on the left and the gastric bypass that you see on the right. And they're both producing similar effects in weight loss. Next slide. Now let's talk about what medications may be coming. And I think it is kind of representing a new era of medications in obesity. Next slide. So the first medication we'll talk about is Semiglottite. The formulation in weight loss is called Wegovy. So many of you will recognize Semiglottite from Ozempic, the GLP-1 agonist used in diabetes. So the same medication was studied in weight loss at a different dose. So with diabetes, the dose is 1.0 milligrams weekly, and the obesity medication is dosed at 2.4 milligrams sub-Q weekly. As you can see on the right, there are a number of tissues at which GLP-1 acts. Simply the GLP-1 agonist stimulates insulin secretion, slows gastric emptying, increases satiety, and causes weight loss. Next slide. So this medication has been studied in the STEP trials, and I'm going to take you through step 1. So here, the population was patients with BMI over 30 or over 27 with obesity-related comorbidities. And patients were either started on Semiglottite 2.4 milligrams sub-Q weekly or placebo. And all patients were receiving modest lifestyle intervention. And the study duration was for 68 weeks. Next slide. So we can see that at the 68-week mark, patients who were on Semiglottite lost a total of 14.9% of their total body weight, whereas those on placebo lost 2.4%. The right panel takes a look at what we call categorical weight loss. So this is the number of patients that are losing 5, 10, 15, or 20% of their total body weight. And I think these numbers are quite impressive. So we see that more than half of patients are losing at least 15% of their total body weight, and more than a third of patients are losing at least 20% of their total body weight. And if you can remember, this is for a proportion of patients, this is beginning to mirror the type of weight loss that we do see with bariatric surgery. Next slide. I'll take you through the other STEP trials. So in STEP 2, a similar protocol was used in patients with diabetes. So semaglutide 2.4 milligrams was compared to semaglutide 1.0 milligram. And this resulted in a 9.5 versus 7% total body weight loss over a period of 68 weeks, showing the kind of marginal the addition of weight loss that you get with the higher dose. In STEP 3, investigators wanted to see how far we can push this weight loss by using intensive lifestyle behavioral therapy. So all patients received 30 sessions with a dietitian and were also put on a low-calorie diet. Patients were then randomized to semaglutide 2.4 milligrams or placebo, and they lost 14% as opposed to 8% of their weight at 24 weeks. Interestingly, so those that continued on the semaglutide for the total 68-week period lost a total of 16% of total body weight. So if you compare that to STEP 1, that's only kind of a 1% difference at 68 weeks. So this trial shows us that intensive lifestyle behavior therapy can get us to lose the weight faster, but at the 68-week period, the total weight loss was similar to those receiving modest lifestyle intervention. In STEP 4, investigators wanted to see whether this needed to be a chronic medication, whether patients needed to stay on that medication to see benefit. So all patients received semaglutide 2.4 milligrams for 20 weeks. And at that point, they had lost an average of 10% of their total body weight. And then for the next 48 weeks, patients were randomized to continue the medication or to receive placebo. So those who stopped the medication, they actually regained 7% of their original 10% weight loss. So I think 2 unanswered questions remain after these studies. Number 1 is, do these medications need to become chronic medications, which is suggested by the STEP 4 trial? So it's going to be very challenging for patients to want to continue to pay for a medication when they're not going to be seeing any added weight loss. So for example, is there a role for intensive lifestyle therapy to be used to transition patients off the medication and allow them to sustain that weight loss? I think the second unanswered question is, do these medications have an effect on mortality and adverse health outcomes, such as decreasing adverse cardiac events? So up to this point, all of our trials in obesity have been measuring total body weight loss. Of course, we do know that there is a decrease in adverse cardiac events with GLP-1 agonists in the diabetes population, but this has not yet been shown in patients with obesity. However, the SELECT trial using the semaglutide 2.4 milligrams in the obesity population is currently underway. And of note, Wegovy, or semaglutide 2.4, was approved by the FDA earlier this year and was also approved by Canada in November of 2021, but it is not quite yet available for patients here. Next slide. Now we'll talk about another agent called Transepitide. So this is a dual glucose-dependent insulinotropic polypeptide, or GIP, and GLP-1 agonist. So both of these are natural hormones produced by the body and released by the enteroendocrine cells. So you can see that both GLP-1 and GIP act on many of the same tissues. GIP also has effect on the fat cells, which is thought to be kind of where the added benefit comes with this medication. And preclinical studies have shown synergy between these two mechanisms. So a number of trials have been done on this medication. Next slide. So I'll take you through a SURPASS-2 trial. So this trial was done in patients with type 2 diabetes and a BMI over 25. Patients received Transepitide 5, 10, and 15 milligrams sub-Q weekly, and this was compared to Semiglottite 1.0 milligrams sub-Q weekly. Unfortunately, at this point, we don't have a comparison with the 2.4 milligram of Semiglottite, as that formulation had not been approved at the time of when this study started. The outcomes were the change in hemoglobin A1C and the change in body weight at 40 weeks. So looking at the top panel, that is the change in hemoglobin A1C. And you can see from going from left to right, that is the change in patients taking 5, 10, and 15 milligrams of Transepitide compared to Semiglottite in brown. So you can see that with the highest dose of Transepitide, there's a HbA1c lowering of about 2.3%, as compared to 1.8% in the Semiglottite 1.0. In the bottom panel, we're looking at that categorical weight loss again. So how many patients are losing at least 5, 10, and 15% of total body weight? And so when we look at how many patients are losing 15% with the highest dose of Transepitide, it's more than a third, so 36%, as opposed to 8% of those on Semiglottite 1.0 milligrams sub-Q weekly. Next slide. So that, of course, is a study done in a population with diabetes, where we, in this talk, we're more focused on patients with obesity. And so that study, looking at Transepitide in that population, is a study that is currently underway called SURMOUNT-1. It is expected to be completed in May 2024. And this study is looking at people with a BMI over 30 or over 27 with related comorbidities, comparing Transepitide at 5, 10, 15 milligrams also to placebo over a 72-week duration. And so Transepitide has filed for approval in the US for the use in diabetes, but of course not yet for obesity, as we don't have, that trial is underway. Next slide. So I think to summarize, I think Semiglottite 2.4 and Transepitide really is quite of a dramatic improvement to the other three medications that we currently have available, given that for a proportion of patients, it's definitely mirroring the type of weight loss effects that we can see with bariatric surgery. So how are we doing with obesity management in Canada? So on a system level, we know that healthcare professionals are poorly prepared to treat obesity, and primary care models often do not lend time to tackling chronic complex health issues such as obesity. With regards to access, there is a lack of adequate access to healthcare providers or programs with expertise in obesity. Wait times for bariatric surgery are the longest of any surgically treated condition. Patients referred for bariatric surgery can wait up to 8 years before meeting a specialist, but this varies widely across the country. And the access to bariatric surgery does not exist in the 3 territories. The other factor is cost. So currently, none of the approved anti-obesity medications that are on formulary, none of the obesity medications are on formulary or covered under any provincial drug plan. And so liraglutide or Saxenda would cost patients $1,200 per month, or Lestat costs about $580 per month. Next slide. Now, how are we doing in Hamilton? So 2 clinics that exist for patients with obesity are the Bariatric Medical Weight Clinic at St. Joe's and the Wharton Medical Clinic. The referral criteria for these two clinics are the same. So patients with a BMI over 35 or a BMI 30 to 35 with an associated comorbidity, or patients who are post-bariatric surgery with complications or weight-related issues. The only exclusion criteria are those who have previously completed a medical weight management program that was funded by OHIP. Services offered at both of these clinics include a visit with the internal medicine physicians, a dietitian, occupational therapist, social worker, and psychologist. And the program may include group support sessions, medications that we've talked about, meal replacements, or where it's indicated, a referral for bariatric surgery. The estimated wait time for bariatric surgery in Hamilton is about 1 to 2 years, although I do anticipate that this is longer now given the pandemic. Next slide. So now we'll leave you with 4 take-home points. So number 1, it's important to recognize obesity as a chronic illness and ask your patient for permission to address it. Adults living with obesity should receive individualized care plans that address the root cause of obesity and that provide support for behavioral change as well as adjunctive therapies. Number 3, current medications that are available for obesity in Canada provide about a 5 to 10% weight loss. And number 4, new pipeline medications are producing weight loss results that mirror bariatric surgery for a proportion of patients. And that's all. Thank you.
Thank you, Alex, Amena, and Abdullah for pretty comprehensive rounds on this very important topic. So again, just a reminder, if you have any questions, just put in the Q&A section. We have quite a bit of time to do good discussion. I see a comment from Dr. Taboni, and I see her actually among our audience. So I'm just going to bring in Maria in to share with us her comment, if that's okay with you, Maria, if you can.
Yes, can you hear me?
Yep, fantastic. Thank you very much for supervising the residents for this grant. It's fantastic.
No worries. Yes, I just wanted to make one comment only, is that we really don't have an age limit for bariatric surgeries in Ontario. We're not supposed to discriminate by age. But of course, after a patient reaches 65, the surgeons want to have a great candidate moving forward. But we actually have done people over 70 at St. Joe's. And I just want to comment on another bariatric surgery that it is covered by Ontario. We're really cranking it up in Hamilton, and it's the duodenal switch, which is a very, very special surgery, very, very malabsorptive, that is really only indicated for people that have a BMIs of over 55 or over 45 with very significant comorbid conditions. And I'd like to thank the residents for bringing this topic up to the light. Because definitely we have to advocate for the care of our obese patients in the city and in the province, and unfortunately unrecognize the need for more advocacy to treat these patients.
Very well said. Thank you very much. So there are a few questions. Dr. Kerner has touched on a couple of important ones. One you touched on, Alex, which is the cost of these medications and not being covered. So how do we really tackle that? You know, with the many patients appear to be eligible for the drugs, but are actually unable to pay for it.
Mm-hmm. So, I mean, the limited experience that I've seen is that really these medications become accessible only for those with private coverage. I don't know if Dr. Taboni has anything else to add to that, but the cost is definitely a barrier.
Yes, absolutely. As Alex says, the cost is the big barrier. The cost, it's around $400 per month. And as Alex was saying, unfortunately, these medications, we have to actually think as long-term medications, the same as for people with diabetes and hypertension. There's no magic pill that will make you lose the weight, and that after discontinuation, you will keep the weight off. We go through private insurance. Sometimes we actually write letters of necessity for use of the drug for the insurance companies. But another point there to advocate with the government to try to have these medications covered.
That's great. Greg's other question is related to any real-life data outside randomized controlled trials in the success of these medications. He talks about the non-completers, which is something that we've experienced in many chronic diseases. Patients don't take their meds. So how do we tackle that, and what's the results of that thing?
Mm-hmm. I guess in this stage of my training, I don't have too much real life evidence, except for knowing that early in when patients are taking the GLP-1 agonists, as we know, many of them are going to experience the GI side effects. For most patients, those do go away with time, but I don't know in this population specifically. Maybe someone can help me.
So I'm not sure if I can help, but usually when patients are enrolled into our bariatric programs, the medication is covered and they do, they don't have any significant side effects. My experience is that they like to stay on them, and sometimes even they like to stay on the medications even if they don't see the weight loss. As Alex was saying, once one of the residents was saying, if you don't achieve more than 5% weight loss from starting, we technically have to discontinue the medications. But there's people in the obesity field, we think, well, if patients don't gain any more weight, would it be justifiable to keep these patients on these medications? We shouldn't technically, but if they don't have side effects and they have seen a good response, they tend to for sure stay on. The other thing that I wanted to bring on is that we have to educate our patients, and we have to let them know that these are long-term medications to use. Again, you stop the medications, you're most definitely going to see the weight going up again. And then you have to balance the cost of patients on medications. 5 years on Saxenda, it's $4,000 per year at best. For 5 years, $20,000 versus the cost of bariatric surgeries, even including the follow-up, right? So patients tend to stand if they have good results. And last comment, the response to any anti-obesity treatment, call it diet, medication, surgery, is actually very, very variable. And in the studies, we see 10% weight loss, and they're very promising drugs, but the individual response is actually very, very variable.
I am interested to know actually if there is a certain point at which, all the studies right now show that we need to continue the medication indefinitely. But we know in weight loss, when patients, achieve a kind of a new set point, maybe that's achieved after 2 years, then it's easier for them to stay at that weight. And I do wonder if there's, a certain amount of time maybe that the patient needs to be on the drug in order to reach that new set point, or if something like intensive lifestyle behavioral therapy could be a bridge to coming off that medication. But I do recognize there's not a lot of incentive to do those types of studies.
Great comments, thank you, and that's very helpful. I brought in Dr. Coffey, who also practices bariatric medicine. Hala, you had a comment?
Yeah, hi, can you hear me?
Yeah, go ahead.
Okay, so as some of you may know, I have a medical obesity practice as an outpatient, but out of Waterdown and Oakville. So just to comment about using those medications in real life versus outside of studies, I usually use them, I use them actually very often in combination with lifestyle interventions, including a strict dietary intervention, as well as cognitive behavioral therapy. I find the barrier to this is actually a lot to do with the patients, because patients can't really wrap their minds around the fact that obesity is a chronic disease of the brain. And some of them think that they're going to use this medication short term, and once they lose the weight, they can get off the medication. So the first thing is, just like Dr. Timoni mentioned, those medications are meant to be used long term, even after they lose their weight, because it helps with avoiding weight regain once they reach their weight goal loss. And then the other thing is that I find that a lot of patients have difficulty with adhering to a dietary intervention without medications for more than a few months, because when you lose weight, all of the mechanisms kick in through your brain to promote you to regain the weight back, either by decreasing your metabolism or increasing your appetite. And so it's like your brain working against the patient really, to gain all the weight that they've lost. So the problem here, and I guess the use of the medications here really is to help them with overriding that mechanism, to help them adhere with their lifestyle intervention and to promote them to lose further weight. And that's why in studies, you see that patients without those medications only lose 3 to 5% of their body weight, whereas when they use the medications, they lose much more.
Thank you, Hala. Dr. Gunstein also has a comment, so I'm going to bring him in.
Hi. You can hear me okay?
Yeah, go ahead.
Yeah. Thanks a lot, Khalid. That was an excellent review and survey of the literature and the status. So congratulations on putting that together. I think just hearing the discussion, I think the most important thing that was said during the rounds and that still people don't get, and it's normal, is that this is a chronic disease. And in the same way that cancer is a chronic disease, depression, psychiatric disease is a chronic disease, diabetes, rheumatoid arthritis, and the approach to this needs to be the same. So in somebody who's treated with any chronic disease, we can try to make it better, and we do have many drugs that do that, but we don't then say, okay, you're done, we're stopping the drugs, go away. They keep being seen. Drugs can be stopped, they need to be restarted again, and it needs to be managed in the same way. Third-party payers need to pay for drugs, just like they pay for drugs for all sorts of diseases. The same with diabetes. It's really, the same with, obesity. It's really quite interesting that many companies, insurance companies, have refused to pay for obesity drugs, saying that it was cosmetic. Hopefully, once the SELECT trial is done, and if it is, in fact, does show the same cardiovascular benefit or greater in these patients as being seen with diabetes with the same drug, only at a higher dose, then that might change the opinions of the insurance company. So, and the last point is that seeing lots of patients on the GLP-1 receptor agonist is that it doesn't just, and these drugs do not just make patients eat less. They actually change their preference for certain types of foods. They start to like foods that they didn't like before and not like other ones. The same with bariatric surgery. Maria can comment that patients do change their preference and the types of foods that they like or not, because the effects of bariatric surgery are not mechanical. You're not just changing the plumbing, you're changing the hormonal milieu, including lots of GLP-1 and other things that are happening. So the approach that you said at the beginning is totally correct. This is a chronic disease like all other chronic diseases, and needs to be managed in the same way to optimize health. So thanks for the presentation.
Thanks, Herzl. There are a couple of comments from Dr. Preptania and a question. So he first of all corrects us that Saxenda is contraindicated in medullary thyroid cancer and not all types of thyroid cancer. He also brings our attention to the Diabetic Canada website with lots of resources around cultural aspects of food and related to glycemic index and how you can really help the cook to improve on things that would be helpful. But the question he has is, what about intermittent fasting in obesity management, which is really, I think we need rounds on that one day. And do you think that Transepitide will replace bariatric surgery in the future? That's a good question.
I can address the first part of the question, which is intermittent fasting. So it's basically like, based on my brief reading on that, I didn't go into a depth of like dietary plans, but like based on my knowledge is that it's usually advising patient to fast for a varying period of time, usually like more than 12 hours or longer. There are many ways of doing that. It could be like alternate days fasting. It could be some other ways. There are multiple ways. And like the algorithm that or the review that we went through, provided by Obesity Association, honestly goes through a lengthy details on how to do the intermittent fasting. Now, based on the evidence, the intermittent fasting can be beneficial in terms of increasing the insulin sensitivity and improving blood pressure control. I'm not sure that there was any effect on the HbA1c control. I hope that answers the question.
Thank you, Amena. Any insight, maybe Maria or anyone else around how that once we can use Transepitide, would that be the medication that will take away the surgeries, like in many other conditions in history that were treated surgically, but then we find the right medication for them and surgery becomes obsolete?
Yeah, no, I agree that, when these newer medications are kind of trying to pair up with bariatric surgery, but unfortunately for us that are not surgeons, there's really nothing that competes with the effects of bariatric surgery. So I don't see these surgeries going away, because even with a 10%, a weight loss, which is 5 to 10%, you see dramatic improvements in so many outcomes, right? But bariatric surgery still for the super obese, for people with BMIs over 50, there's actually no question that they should go straight for bariatric surgery. I wanted to thank Dr. Garcia for the words, because he put it in very clear words, that this obesity is a chronic condition. We still have this fantasy that we're going to treat people for a few months and then they're not going to need anything. And we cannot think of any other chronic condition that, we have actually that approach. And also, I would like all of you guys to refer all of you guys to the the new obesity guidelines, because they're very good guidelines that were published only a few years ago, and they have been updated in terms of treatments and also in terms of recognizing our own biases and the cultural appropriation and obesity and the intergenerational trauma that has led to obesity as well. So very good chapters actually to read. And the other thing that I wanted to say is also we have to change our mind. When I started 10 years ago working with the surgeons, I used to do presentations saying these bariatric surgeries are abdominal surgeries that cause malabsorption. And these days, we recognize that bariatric surgeries produce very significant physiological changes that alter energy balance. And I like to say now they have a degree of malabsorption, the degree of food restriction, but this is how has changed the concept of bariatric surgeries these days and how they are so effective.
Very, very good comments. Thank you. Thank you, Maria. Again, Greg brings in a point which is really interesting, and I was thinking of that at one point myself, is about are those medications like the Ozempic and the Semiglottite, have been studied to the maximum dose to show efficacy? Could it be used at a lower doses for maintenance? And he talks about patients using Ozempic every 2 to 4 weeks to balance cost with efficacy. Based on patients' individual experiences. Is that something you could advocate for, or do we have to maximize the dose on everyone as per the trials?
Well, the idea is to maximize the dose to actually get most of the effects, right? But there might be a role for a lower dose or for weight maintenance. I think, I try to think, when I'm not at the bariatric clinic and I'm in my office or internal medicine, if I think that, helping people lose weight is titanic, and sometimes, it looks like it is, well, just think about advocating for people not to gain any more weight. And if you have your patients in your office, and of course, we want them to lose weight, but if 10 years ago, we have actually stalled the weight gain across Canada, we will be in a very different place today, right? So advocate for weight maintenance along with weight loss. And we'll see if down the road these medications or new medications pair up completely, and if there would be a role. I don't think right now to use these medications for weight maintenance.
Thank you for the comment. Last question. You mentioned about advocacy that's happening at the government level, but there's a comment here around, true pharmacoeconomics, and we know that the cost of obesity is much more than those medications could be. And Herzl brought in the idea of cardiovascular benefits, but we know the harm of obesity is way more than just cardiovascular harm. So is there any advocacy at the government level looking at pharmacoeconomics and the cost of obesity on the individual and compared to the price of these medications?
It's Herzl here. The answer is the companies that manufacture these medications have all sorts of incentives to make their case to Ontario and to all the provincial drug plans, and I am sure they are, and they have, but I don't know any specifics about them, so we'll have to wait and see.
Thank you, Herzl. Well, we're on a time. This is fabulous. Thank you very much, Amena, Alex, and Abdullah for this, comprehensive, evidence-based, really engaging round, and really, really helpful and engaging discussion at the end. So learned a lot and enjoyed your round today, and I hope everyone did. And I wish everyone a great day, and thank you very much, and enjoy the day. It's a sunny day today, cold. Right. Have a good day. Bye.
Yeah.